All right, so this was a 91-year-old male veteran with severe aortic stenosis coming in for a coronary angiogram prior to a planned TAVR. Past medical history is notable for severe peripheral vascular disease in his bilateral lower extremities, so actually that precluded a transfemoral TAVR, so the plan was going to be for a percutaneous subclavian TAVR. He was symptomatic with dyspnea on exertion, worsening exertional capacity. Normally EF on echo, he had criteria for severe aortic stenosis. His STS risk of mortality was 8.5%. He was pretty adamant he did not want any surgical intervention. He just wanted TAVR. Didn't want any surgery at all. So we start with the diagnostic angiogram, 6 French right radial access. You can see he's got severe osteal OM disease. There looks like there's probably some hint of proximal circ disease, and you can also see the proximal LAD is heavily calcified, and there's disease there as well. Just another caudal projection trying to show that proximal circ. You can see here probably a little bit more convincing that there's severe disease there, although it's still a little less than ideal image. As far as the LAD, clearly severe, heavily calcified proximal lesion. I don't know why this freezes for a little while, but more distally. More distally, you can see that there's a severe disease there as well. That's also probably at least moderately calcified. RCA also has severe proximal disease, but not as calcified as the other disease. So, I mean, at this point, when you have severe 3-vessel disease, you always have to ask, should we abandon this plan for TAVR in favor of CABG or surgical AVR? But the patient was very clear that he did not want any surgical intervention, and before we kind of had this discussion, he just wanted PCI, which we felt comfortable proceeding with here. Question before TAVR often is, which vessels and what lesions you have to go after and revascularize. I think here we're pretty comfortable saying he had major vessels, severe proximal disease. We're comfortable saying that he really needed each of these lesions treated. Sometimes you might want to go after the easier lesion like the RCA for kind of some low-hanging fruit rather than the more complicated stuff first, just so you have some sort of vessel being perfused, but we really thought the left-sided territory was a little more important and wanted to start there. Impel support wasn't really an option because of his peripheral vascular disease. A balloon pump really wasn't going to help us too much. We're a radial center. He did have bad peripheral disease. Probably could have tried a PCI femoral, but we were comfortable just staying radial. Figured we needed atherectomy at least for the LAD. Weren't sure about the circumflex system as much. So for the LAD, we wired it with a rotofloppy, took a 1.5 millimeter burr. Did 2 passes on the proximal lesion, also decided to hit that distal lesion as well just because it was calcified. We were able to easily expand a balloon down there after atherectomy, and then in the distal lesion we put a 2.5 by 20 millimeter stent. We got a nice angiographic result there. For the proximal lesion, we hit it with that 2.5 NC balloon on the way out before we stented the distal lesion, and then after we put that distal stent, we dilated it some more with a 3.0 NC balloon. Positioned a 3.0 by 22 millimeter drug-eluting stent. Approximately, thought we had a landing zone there in the proximal LAD. Tried to land it kind of before that aneurysmal section after the lesion. Deployed our stent. Had a pretty good result. Wound up post-dilating it with a high-pressure balloon. We were pretty happy with our final LAD results, given what we started with. Decided to move on to the circumflex next. Our question here was really what bifurcation strategy we wanted to employ, whether we'd need atherectomy, and we figured that we would benefit from some intravascular imaging. So we went ahead and IVUSed the circumflex just because we weren't really seeing it well on angiography. We were able to confirm that there was diffuse disease in that proximal segment involving the bifurcation. It was calcified. MLA was 3.96, so we were pretty convinced this was a true Medina 111 and that we needed a 2-stent strategy up front. We had a wiggle wire in the LAD from the LAD intervention, left that in place for support. We had the OM and the circumflex wired, tried to pre-dilate. You can see here we didn't get very good expansion. There's dog boning of that balloon. So decided we had to go ahead and atherectomize the OM lesion. So we pulled our wires out, switched out for a rotofloppy one with the same 1.5 millimeter burr, did a couple passes for that OM lesion. Rewired, or we exchanged the OM wire for a wiggle wire and then rewired the circumflex. This time we were able to expand the lesion pretty well. For bifurcation, we kind of wanted to keep it simple at this point, minimize our wire exchanges and kind of because it was kind of a long procedure at this point. So we just went with like a simple mini crush. So we deployed a stent in the OM, a 2.5 by 15, extending back into the circumflex. And then we actually crushed with a non-compliant balloon, which actually kind of caused some problems for us instead of crushing with the second stent, because it doesn't project very well here, but we were having a lot of difficulty delivering the stent to the circumflex after that. We thought we were getting caught up on that first OM stent. So what we had to do is interworm a guideliner down and then unsheath our stent, which was a 3.5 by 18 millimeter stent. So we deployed it here, did kissing balloon inflation after that, and we were pretty happy with our final result in the circumflex. So we called it a day for that, brought him back a few weeks later to do the RCA PCI, which was a lot more straightforward. Just wired it with a Xi'an blue, pre-dilated with a 3.0 by 15 NC balloon. And then we went with a long 3.5 stent, just covered the entire disease segment, and had a pretty nice result on the right. So the patient tolerated everything very well. Initially, when I submitted this case last month, he was scheduled to have the TAVR this month, so I was going to show the results of the TAVR. But he actually felt so much better symptomatically that he postponed the TAVR and is kind of now refusing it. So kind of a good end, I guess, but he still got severe aortic stenosis. So thanks.
Very good case. I have a couple of questions for the panels. One question is, how high risk when you have a severe aortic stenosis and if you have a multivessel disease to do the PCI? Just not particularly this case, suppose you have a peripheral artery, no peripheral arterial disease, one. Or second question is, if this patient not multivessel disease, just medial AD lesion, 90%, or mid circulation, or both mid, or one area proximal severe lesion, do you just do the TAVR first or do the PCI first?
So, you know, in our lab, it seems to waver case by case. Things that change your decision making is LV function, heart failure symptoms or not, and the criticality of the coronary disease and what you're going to need to do. I've seen it both ways, where they will do a BAV and then proceed with the left system like you did here. And I think, by the way, that was a tour de force of getting the left system done, all in one shot. I've also seen the opposite, where they'll do a TAVR, get the patient through, and then bring them back and select the coronaries to be treated. So I don't know what you're doing, Kirk, but you know, it really varies on a number of different aspects of the patient and the care and what they're coming in for.
We tend to address the coronary disease first. That's our usual approach. But you're right, Manish, there's a lot of different ways of going about it, and there's arguments in both directions. Quick question, what was his aortic valve area estimated to be?
0.95.
0.95, yeah. The reason I ask is we all know that AS is like the thinnest device to go out, you know, dancing on. And this is one of the settings where I think the old brown wall criteria, 0.4 millimeters squared per meter body surface area, is a really useful number to have in your hip pocket, because once patients have a valve area that's less than 0.4 per meter squared, their tolerance of the kind of work that you did just vanishes, or it's dropping at a precipitous rate. So in a guy, he's probably had a BSI of, you know, an average guy's going to be 1.8 or something. So you're talking about a valve area then kind of 0.6, 0.7 range, which I think most of us would say that feels right. You know, a valve area in that range, they just don't tolerate anything. And I applaud the work that you did. It is an extraordinary outcome for this very sick guy. I do think that you had an angel sitting on your shoulder through these cases, because rotational atherectomy and an LAD with a sick as stink circ and a sick as stink right and a guy with bad AS, boy, I tell you, that just makes me sweat thinking about it. Yeah, nice job, very nice job. I do think that if his valve area had been a little worse, you would have had much more trouble. And I understand he's 91, he doesn't want to get an operation and so forth, but let's not forget, the whole idea of integrating patient preference and so forth does not mean that you are a vending machine. Your duty is to explain to the patient their best option and push them in the direction of making the wisest choice. And he may have refused, that's fine, but you have to document clearly that you had all the facts laid out and explain things to the patient and the family in terms they understood. to confirm that they've made a wise choice.
I have a question for you.
Sure.
So if this patient did not have a peripheral vascular disease, would you put Impella in this case, or how
Yeah, I
difficult
mean, that's
would
another
you
thing
think
with-
that with the severe AS, Impella, crossing the Impella and putting that do you have any practical experience on that?
I don't. I kind of asked my attending about it, and in his experience, it's been done.
It's not well tolerated.
Yeah.
The whole system tends not to function very well when you've got aortic valve disease, even though it's stenosis, more of the regurgitation, the valves are diseased.
Mhm.
They're thickened and rigid. Once you put a big device through, if it holds the valve open, you get so much AI. That,
Okay.
So I want to call out my structural fellow who just graduated. Poonam is in the back there. She's 4 weeks out of her training. And Poonam, how would you have done this case? Or how would you do it now if you had this multivessel disease, normal ventricle, critical AS? What did you take away from your... Yeah. Is that what we would have done? BAV in this case? Yeah. 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 Yeah, I mean, I think that's just what you had said, Kirk. With that, you know, an angel's got to be sitting on your shoulder to get by without something, you know, with a fixed cardiac output and doing, you know, rotational atherectomy and having that, you know, that circ bifurcation.
Good point.
Great.
Thanks.
There are certain patients who are critical to experience and they are asymptomatic. You know, maybe his symptoms are all from coronary artery disease, not from aortic stenosis.
Maybe so. And
Could be.
One, if he feels great
Could
after
be,
coronary
yeah.
work,
Yeah.
leave him alone.
And other question is, it comes into our mind when we do this procedure as well. Like stent in his LAD, there was post-stenotic dilatation, you know, aneurysm. Sometimes you have to leave a stent in, and obviously you can't oppose that stent to that area. So what is the long term in this kind of experience?
As long as you have good optimal expansion and disease coverage, there's no downside.
But optimal explanation in a stenotic area, but an aneurysmal area, you cannot.
As long as the stent is optimally expanded, there's no price to pay. That's what we've learned from imaging.